Good evening, everybody. First, I want to thank the board of our prestigious Egyptian Otolaryngology Society, represented by its president, my dear Professor Sami Alwani, and its secretary, my dear Professor Osama Abdel Nasir, for the continuous support to hold this event. And also the thanks go to my dear Professor Muhammad Badreddin, the man who pioneered endoscopic ear surgery in Egypt. My talk today is about the role of endoscopy in managing cases of post-traumatic facial nerve paralysis. Indeed, the managing of post-traumatic facial nerve paralysis has many debatable issues and queries, making it a real dilemma. So, there are many concepts to be considered to solve this puzzle. The first issue is concerning with the onset of the paralysis. If the paralysis started with the trauma as a complete nerve block or partial block with progressive cause, the facial nerve must be explored, guided by the CT findings revealing the direction of fracture line or lines. In other cases, wait and see. 2 weeks with steroid and conservative measures concerning with eye care and static massage of the facial muscles. If there is no improvement, please ask for electrodiagnostic tests, especially electroneuronography. 90% or more degeneration is found, the facial nerve must be explored. Less than 90% degeneration, please go to physiotherapy option with monthly follow-up for 3 months by clinical examination and electrodiagnostic tests. During this period, if there is worsening of the condition or after this period, there is no improvement, please explore the nerve. Now the battle is beginning. Many years ago, the microscopic post-auricular approach was the only to explore the facial nerve as shown in this video. And of course, here is the facial nerve and here is the site of the injury. But fortunately, in recent years, the endoscope emerged in otology and neurology fields, giving us a great detailed panoramic view of all middle ear structures, including the facial nerve. Of course, I mean both parts of its tympanic segment with direct access. To clarify my point, let me show you this case of neglected foreign body in middle ear causing facial nerve paralysis. After removal of the foreign body here, which was stone, the real challenge is to discover the site of the injury of the facial nerve after dissection of the granulation tissue surrounding the facial nerve canal. Here I started anteriorly, which is more safe, and here, of course, this is the site of the exposed facial nerve, which is the part of the facial nerve injured by the foreign body at the level of the second genome. Many papers stated that the geniculate area as one of the most common sites of the affection of the facial nerve after trauma, corresponding to the findings I revealed in my clinical practice. And here, an example for these cases managed by a transcanal approach endoscopically after elevation of the tympanomeatal flap and removal of the incus to reveal the postcochleariform part of the tympanic segment of the facial nerve, which was intact. I needed to decapitate the head of the malleus to reach to the pregeniculate ganglia. And here, the depressing bone segment compressing on the facial nerve at the site of the geniculate ganglia and the precochleariform part surrounded by hematoma. After decompression of the facial nerve and the evacuation of the hematoma, we reconstruct the ossicular chain by fashioning the incus between the handle of the malleus and the head of the stapes. For sake of patient's confidentiality, I compare the upper and lower halves of the face pre and post-operative separately. Here is the upper half pre and post-operative photos. Here, a great challenge is emerging concerned with the post-operative hearing results. With increasing learning curve of using the marvelous bone semen in ossiculoplasty, we got a very satisfying hearing results post-operative. And to clarify my point, let me show you this case after removal of the ankles to visualize the tympanic segment or the postcochleiform part, then mobilization of the malleus without need for decapitation of its head. We found dehiscent bone surrounding the geniculate and the precochleiform part of the facial nerve. So coverage of the dehiscent part of the facial by using perichondrium, and the really challenge was the reconstruction of the ossicular chain by putting the ankles in the anatomical position and fixing it to the stapes and to the malleus by using bone cement. And I recommend to use a cone with using bone cement. Please note the movement here on the round window niche. That's stabilizing, that proving the stability of the ossicular chain, then the construction of the removal bone by the outer attic mass by a piece of cartilage, then the construction of a small tear in the flap by using perichondrium transperforation. Another important point concerned with the great panoramic endoscopic view, increasing the learning curve of the audience, as shown in this video on Instagram, shared by one of the attendees of the operation to the step of the reconstruction of the ossicular chain. The pediatric patients are another challenge, but based on my facts, it's not an obstacle if you use endoscopes with suitable diameter. To clarify my point, here is a case of right post-traumatic facial nerve paralysis in 2.5 years old child that was managed by 2.7 millimeter 0-degree endoscope after elevation of tympanomeatal flap and removal of the ankles to reveal the site of injury of the facial nerve, which was the tympanic segment, then covering it by using perichondrium, and finally reconstruction of the ossicular chain by using and fashion the ankles between the handle of the malleus and the head of the stapes, and here relocation of the flap again in place. These are the pre and post-operative photos of the upper half of the face, and here is the lower half. Now, please don't make the mistake of believing that the post-auricular microscopic approach in managing the post-traumatic facial nerve paralysis is an old technique, and the endoscopic transcanal approach is a new one. That's a fatal mistake. The best proof of the error of this belief is that case with a large fracture in the mastoid, as shown in the CT. Here is the video of the operation. By using the microscope post-auricular approach, we reveal here a large segment of the mastoid fractured and with bone loss. Of course, the first step to identify the facial nerve is performing antrostomy. Then detection of the facial nerve just beneath the lateral semicircular canal here. Of course, here is the proximal end of the injured facial nerve in the mastoid segment. And this part of soft tissue is the stapedius muscle here. It's the stapedius muscle within the mastoid bone, and here is the pyramid, and of course this is the stapedius tendon. Detection of the distal end of the injured facial nerve and making a tunnel in the mastoid bone for future grafting of the facial nerve by using a great auricular graft. Here is the distal end, this is the proximal end, here is the groove. This is the part of the great auricular nerve that was dissected from the incision, and then putting it in the tunnel. And here is the final view, that's the cable of the great auricular nerve, then coverage the graft by using temporalis fascia. These are the pre and post-operative photos of the upper half of the face of the patient. And here are the photos of the lower half. Of course, the post-operative photos taken 9 months post-operatively. Finally, may you take the home message. The concept of struggling between endoscope and microscope is nonsense. You must tailor your management according to the case. use the tool and the technique giving you the maximum benefits. You are not a microscopist nor an endoscopist, you are an otologist. Finally, may I invite you to join us and participate in our next activities. Here is the photo that I'm proud of it, of the members of the Egyptian Working Group in Endoscopic Ear Surgery with our prestigious board of the Egyptian Otolaryngology Society. And this is our WhatsApp group admin, and here's our Facebook page. And for scientific activities and coordination of workshops, may you contact me with pleasure. Thank you for your attention. Now, as we are beyond the time, about 1 hour, so we are going to begin the third session with launching of the Pan-African Endoscopic Ear Surgery Federation. And of course, our great prof, Dr. Mohammed Badreddin, is the honor to present this session. And may I present the welcome message, as it's an honor to present the welcome message of the Federation. The official welcome message is the Pan-African Endoscopic Ear Surgeons Federation is an association established under patronage of the Egyptian Otolaryngology Society. It's founded by the members of the Egyptian Working Group for Endoscopic Ear Surgery in cooperation with a number of eminent African otologists experienced in endoscopic ear surgery. And it aims to widespread the endoscopic ear surgery skills all over Africa by organizing periodical scientific activities, either virtual or hybrid demonstrative events. All African otologists and those interested in endoscopic ear surgery globally are invited to contact the board of the Federation for exchange experiences and coordination of the upcoming activities serving the goals of the Federation. First, I want to give a brief introduction in 5 minutes on endoscopic ear surgery in developing countries after the valuable words of my dear Professor Dr. Sami Alwani and my dear Professor Dr. Mohammed Badr. So, Dr. Sami. Please, Dr. Sami, unmute yourself.
Okay. It's my pleasure to be again with you in the launch of this great federation, the Pan-African Federation of Endoscopic Ear Surgeons. This is a very important step. We all belong to Africa, and we share the same, as Dr. Adel said in the opening ceremony, we share the same problems, the same social factors, the same economic factors, and it is time now to work together to spread the practice of endoscopic sinus surgery as we did before with the practice of endoscopic ear surgery as we did before with endoscopic sinus surgery. We want to be the same experience and spread the training and the knowledge beyond even the borders of our countries to all Africans, hopefully in the not too far future. We are starting today maybe with 6 or 7 countries, but I'm sure that next year will be more countries, up to 25, as I heard from my colleagues. I wish you a good start for the Federation, and I am sure that we'll be doing better and more in the future. And welcome again to Egypt. Professor Waleed.
Doctor, the words of Dr. Mohammed Badr.
Thank you, Dr. Waleed, for giving me the chance to welcome my friends and my colleague from Africa. And actually, the Pan-African Endoscopic Ear Surgeon Federation was like a dream for me to make it come true. Since we started the international working group, we were actually promoting endoscopic ear surgery all over the world. And now as president, I am the president of the International Working Group on Endoscopic Ear Surgery. And we had actually lots of branches under the umbrella of the International Working Group. We have the Pan-Asian, we have the All India, we have the Pan-American, which combines the Latin American with the America. We have the European. Actually, in every region, we had a branch for the international working group, and those branches are all or come together under the umbrella of the international working group. We then, several years ago, we decided to do the Egyptian working group on endoscopic ear surgery, and that's actually was relatively very active too, and we had this intention of getting the all Africa together, and was, you know, really Africa has a real place and weight in surgery. And several years I started going to with my dear friend Chimi Oland in Kenya, and we were doing endoscopic ear surgery courses and getting otologists from all over, actually around Kenya, and then Sudan, and then South Africa. I really was impressed a lot by how my friends and my colleagues in Africa are interested in endoscopic ear surgery. And I was talking to my colleagues in the international working group about how Africa is a place. Now, this is this is a reality now, and we have Africa in place. I'm also very happy that it brings the French and the English. We have the Francophone and the Anglophone. So we have Morocco, we have Tunis, we have Algeria, which is great. And on the other side, we have French-speaking African, and we have the English-speaking African. So it's really very interesting. I have my friend Hassan Chili from Morocco, and we have even from Dr. Yazid, and we have many others in Tunis. So we are actually now, it's time, and we are mature enough to make this Pan-African federation that will combine, will promote the endoscopic ear surgery forward. Definitely, we will have a place next year in the World Congress of Endoscopic Ear Surgery, and the Pan-African World Federation will have a place in Kyoto meeting next April in 2022 in Japan. So let's start working and preparing for our next World Congress, fourth World Congress that will be in Japan, and we will be presented this time as African nation. And thank you very much for Waleed, for all the efforts you did to make this world federation. I know you did a lot in this work, and I'm very proud of what you did actually. I welcome all my friends from Africa, and I'm looking forward to meet you in person, physically, and very soon. And I'm very happy to have you today to present in our first meeting together. And thank you very much. Thank you, Waleed.
Thanks, Dr. Bad, my mentor, indeed, for the kind words for me. First, I want to give a brief introduction in 5 minutes on endoscopic ear surgery in developing countries. Alaa. Alaa, you can start. علاء معايا؟ علاء. علاء.
ايه يا دكتور هنعرضها حالا.
طيب يعني.
وقفلوا الفيديو ولا ايه اللي عندي بس؟
لا مش علاء، مش دي علاء.
دكتور وليد هو محاضرة حضرتك صح؟ اللي جاي.
ايوه محاضرتي اللي هي الخمس دقايق. First, I want to welcome our high-profile guests from all over Africa. May I give a brief introduction on the endoscopic ear surgery in developing countries? Of course, there is a difference among practicing medical aspects in variable countries according to economic conditions of each. So, discussion of the availability of instrumentations and endoscopes of endoscopic ear surgery in our countries is a matter of great importance. First, I'll discuss the availability of the endoscopes. As regard to the lens, of course, the ideal lens for endoscopic ear surgery endoscopes is between 14 to 16 centimeter working length. But in my clinical practice, the use of 17.5 centimeter endoscopes routinely used in functional endoscopic sinus surgery is very applicable. As regard to the diameter, despite the 3 millimeter endoscopes are ideal for endoscopic ear surgery, I always use the 4 millimeter ones in ease. So, in practicing endoscopic ear surgery, I always use the 4 millimeter 17.5 centimeter endoscopes, which are present routinely in hospitals for functional endoscopic sinus surgery. And in our thesis published in Journal of Otology about endoscopic staphylectomy, we used the previous ones. For pediatric age group, you may use endoscopes of 2.7 millimeter diameter and 11 centimeter working length that's used mainly for otoendoscopy. As regard to the cameras, of course, the higher the specifications of it, the better detailed panoramic view is gained. This is one chip camera view, and here is the high definition SPICE camera view. As regard to instrumentations, remember that the instrument is your tool, so choose the right tool for the job. Try to use one instrument for multiple purposes to save the time and minimize the cost. Here is our sickle knife, which could be used as a scissor by its sharp blade, as a needle by its tip, or as a dissector by its blunt blade. Your angled instruments are far more better in performance. Dr. Panetti pioneered special set of instruments for endoscopic ear surgery with suction. Here is a part of this set. If you find it costly, may I recommend these two pieces only, as I found them very beneficial in my own practice. So, endoscopic ear surgery is giving marvelous solutions for country finance. That's because no special endoscopes nor instrumentations are needed, only the endoscopes present routinely in hospitals for functional endoscopic sinus surgery and the ordinary instruments for otological procedures. So there is no additional cost. The concept of surgeons without scalpel, termed as transnatural orifice surgeries, are widely accepted in all medical fields, including otorhinolaryngology, promoting one-day surgery to lower the cost of post-operative hospitalization of the patient. As regard to the high cost of cadaveric dissection courses, fortunately, the Modena team developed an endoscopic ear surgery training course on cheap model with 3 tasks: elevation of tympanomeatal flap, ossiculoplasty, and tympanoplasty. And I added staphydotomy and facial nerve compression tasks. in the courses moderated by me. This video is showing us the anatomy of the middle ear of the sheep. Of course, this is the ankle, this is the malleus. Some sort of different about the human. The online communication is a very beneficial tool for education nowadays. So may I invite you to follow and participate in our activities in the Egyptian Working Group in Endoscopic Ear Surgery and our emerging star, the Pan-African Endoscopic Ear Surgeon Federations. Finally, may you take the home message. 1. Practicing endoscopic ear surgery is applicable in developing countries without any additional cost. The training